начать эфир.
Да. А как потом закончить? Позвать вас?
Да, ну или кнопку вот завершить трансляцию.
И все, да?
Я уже дальше все сам сделаю.
Трансляция началась?
Да.
А аудитория есть, да, там?
Можно спросить, да, чтобы они писали сюда плюсики, если они слышат. Задержка 30 секунд будет.
Хорошо. Мне как-то их фиксировать же не нужно сейчас уже в свете новых событий, да?
По вашему желанию.
Я понял. Хорошо,
Я
спасибо.
пока не ухожу далеко, я здесь.
Да, спасибо. Hello, dear colleagues. First of all, I want to congratulate you with the beginning of new study year. I hope that you have successful holidays. And let's begin our first lecture by hospital surgery. And the topic of our lecture today is a systemic inflammatory response syndrome. Colleagues, please, who is present here? Please write me in direct your name, surname and name, group number, and plus. Okay? Thank you very much. Let's begin. Systemic inflammatory response syndrome. Что-то у меня слайды не переключаются. Just a moment. Some technical problem. А можно вас на минуточку? Okay, it's okay. So, systemic inflammatory response syndrome and sepsis and its diseases of spectrum. Because sepsis is like a part of systemic inflammatory system and is one of the most dangerous also and beginning phase of systemic inflammatory response syndrome. So various stages of diseases can be. It can be bacteremia, it can be SIRS, it can be sepsis syndrome, it can be septic shock, early or refractory. Definition. Etiology, it can be, of course, by etiology, definition of SIRS and sepsis. So it can be infection, presence of microorganisms in a normally sterile site. Okay, colleagues, thank you very much. I see you who is present. And if will be new students, please also write your names here. Thank you very much. We continue. So it can be infection, it can be bacteremia, cultivatable bacteria in the bloodstream. It can be sepsis, systemic response to infection, if associated with prevalent or clinically suspected infection. SIRS is called sepsis. What is it, SIRS? Systemic inflammatory response syndrome. It's a wide range of stresses. So what symptoms will be? First of all, it's usually temperature and fever more than 38 degrees or less than 36 degrees. Heart rate usually will be more than 90 beats per minute. Respiratory rate is more than 20. White blood cells usually more than 12 cells or less than 4,000 cells. Note, 2 or more of the following must be present. These changes should represent acute alteration from baseline in the absence of other known cause for abnormalities. Severe sepsis. Sepsis with organ hyperperfusion, one of the following. SBP is less than 90 millimeters. Acute mental status change. pure oxygen is less than 60. Increased lactic acid or acidosis. Oliguria. DIC or platelet is less than 80,000. Liver enzymes is usually more 2 for normal, so twice will be more than normal. What is it, MODS? MODS is a multiple organs dysfunction syndrome. Sepsis with multi-organ hyperfusion Two or more of the following symptoms will be SBP is less than 90, acute mental status change, pure oxygen less than 60 millimeters, increased lactic acid or acidosis, oliguria, DIC or platelet less than 80,000, and liver enzymes is more than 2 normal levels. Relations between SIRS and sepsis here on this slide you can see. Of course, will be usually etiology factors of the sepsis. It can be infection, it can be bacteremia, which to these etiology causes give sepsis, and then sepsis can complicated for SIRS. Also, like factors of the etiology of SIRS and sepsis can be trauma, can be burns, can be acute forms and complicated forms of pancreatitis and other signs. On this slide you can see sepsis continuum. It SIRS, sepsis, severe sepsis, and septic shock. For SIRS, clinical response arising from a non-specific insult with two of the following: temperature more than 38, HR more than, heart rate more than 90, RR is more than 20 per minute, white blood cells is more than 12 or less than 4. For sepsis, usually SIRS with presentment of or confirmed infection process. For severe sepsis, it's usually sepsis with organ failure. Septic shock, refractory hypertension. And you should remember that SIRS is a systemic inflammatory response syndrome, and MODS is a multiple organ dysfunction syndrome. Usually, MODS is like a part of the SIRS. On this picture you can see mortality rate in case of SIRS. You can see how it can increase from minimal to maximum. Usually mortality from the SIRS usually is very high, and usually this patient is for ICU department because these patients have a lot of complications and polyorganic insufficiency. On this picture you can see the response to pathogens of crosstalk. A lot of microorganisms, bacteremia, trauma, septic shock can give polyorganic insufficiency. And this is mechanism how it can be. Crosstalk of the infections and etiological processes. On this picture you can see inflammatory response for sepsis and the pathogenesis of it. Next slide. Procoagulant response in sepsis. Also, it's pathological and pathophysiological process, and usually, like I told before, is a sepsis give start for SIRS and MODS. Pathogenesis of sepsis and septic shock, you can see here, is a lysis bacterial cells which give lips bending protein. Here, next step is the LPS and LPS binding protein complex. Then macrophages, of course, will be here with cells of CD14, CD11, CD18, and always this go for TNF, interleukin 1, interleukin 12, interleukin 6, increasing in the blood will be especially for you. And for adults, respiratory distress syndromes usually will be happen. That's why also patients need ICU department, and a lot of these patients need artificial ventilation of the lungs. Next, pathogenesis of severe sepsis. Usually, of course, first of all, it's infection. Then, microbial products, exotoxin or endotoxin, which enter to the cellular to the cells and give cellular response. After it will be platelet activation, coagulation activation, oxidases, kinin complement, and cytokines here, TNF, interleukin 1, and interleukin 6. All these go for coagulopathy and DIC syndrome, DIC syndrome, vascular organ syndrome injury. After that, endothelial damage, multiple organs failure, and endothelial damage also is give multiple organ failure. And unfortunately, it can happen all this with death. Normal systemic response to infection and injury. Mobilize neutrophils into the circulation, increases cardiac output, blood flow to injured tissues, raises core temperature, peripheral vasoconstriction, shunts blood flow to injured tissues. Occurs much more often when infection is a trigger for systemic response. Normal systemic response for infection and injury. Continued acute phase response. Anti-infective. Increases synthesis of complement factors, micro pattern recognition molecules, monos, binding lesion, LBP, CRP, CD14, and others. Sequesters iron, lactoferrin, and zinc also can be discharges. Anti-inflammatory. Releases anti-inflammatory neuroendocrine hormones, cortisol, ACTH, epinephrine, increase synthetic of proteins that help prevent inflammation within the systemic compartment, cytokine antagonists, anti-inflammatory mediators, protease inhibitors, antioxidants, and reprograms circulating leukocytes. Procoagulants. Walls of infection prevent systemic spread, increases synthesis of release of fibrinogen, decrease synthesis of protein C, antithrombin 3, metabolic, preserves euglycerinia, mobilizing fatty acid, amino acid, epinephrine, cortisol, glucagon, cytokines, thermoregulatory function, inhibitors microbial growth, fever. Risk factors of sepsis. Aggressive oncological chemotherapy and radiation therapy. Why? Because all this therapy will give very high immunosufficiency. That's why it's a risk. Use of corticosteroids and immunosuppressive therapy for organ transplants and inflammatory diseases also like a risk for beginning these problems. Longer life of patients predisposed to sepsis, elderly, diabetes, cancer patients, patients with major organ failure, and with granular cytopenia. Neonates are more likely to develop sepsis. Increased use of invasive devices such as surgical prostheses, inhalations equipment, and intravenous and urinary catheters. And next is indiscriminate use of antimicrobial drugs that create condition of the overgrowth, colonization, the subsequent infection, by aggressive antimicrobial resistant organisms. Patients at increased risk of developing sepsis. Underlying diseases is neutropenia, solid tumor, leukemia, deproteinases, cirrhosis of liver, diabetes, AIDS, serious chronic conditions, surgery or instrumentation, catheters, prior drug therapy, immunosuppressive drugs, especially with broad-spectrum antibiotics. Age, usually it's males above 40 years old and females 20-45 years old. And miscellaneous conditions like childbirth, septic abortion, trauma, and widespread burns, intestinal ulcerations. All this is risk factors for SIRS. Source, usually an endogenous source of infection. It's intestinal tract, oropharynx, instrumental sites, contaminate inhalation therapy equipment, IV fluids, most frequent sites of infection, lungs, abdomen, and urinary tract. And other sources include the skin, soft tissues, and the CNS. And especially for now, like for COVID-19, for coronavirus, also is the same risks. Intestinal tract, most usually, of course, oropharynx is the eyes. Also can be any contaminated inhalation therapy. Of course, it can be gates for infection for coronavirus. And really, it's really hard for now. A lot of patients is sick. And why is it very dangerous and why it's also can give SIRS? Because very high level of contamination is the first. Second, very high level of the mortality, very high level of polyorganic insufficiency. But first of all, it's of course pneumonia. It begins from pneumonia with very high or subfebrile temperature. And after pneumonia, also can begin insufficiency of oxygen. And after it, like a next step, begin our other problems like respiratory insufficiency and then polyorganic insufficiency. That's why take care and be carefully for you. Diagnosis. History. Community or nosocomially acquired infection. Immunocompromised patients. Exposure of animals, travel, tick bites, occupational hazards, alcohol use, seizures, loss of consciousness, medications. Underlying diseases, specific infectional agents. Some close to septic events include fever or unexplained signs with malignancy or instrumentation, hypertension, oliguria or anuria, tachypnea or hyperpnea, hypothermia without obvious causes, and bleeding. Specific infections agents. Splenectomy, traumatic or functional. Here will be usually can be is pneumonia, influenza, meningitis. Next is a neutropenia, less than 500 neutrophils for 1 milliliter. Gram-negative microflora usually, including P. aeruginosa, gram-positive, including Staphylococcus aureus, fungi, especially Candida. Next one is a hypergamma-globulinaemia, and here is a Streptococcus pneumoniae and Escherichia coli. Main and last one is a burns. Also can be AIDS, intravascular devices, nosocomial infections, and septic patients in India or Thailand. Is a specific. Diagnosis: physical examination, divided for essential, and in all neutropenic patients and in patients with a suspected pelvic infection, the physical exam should include rectal, pelvic, and genital examination. Perirectal or perineal abscesses, and pelvic inflammatory diseases and or abscesses or prostatitis. Signs and symptoms: non-specific symptoms of sepsis, not pathognomic. Fever, chills, constitutional symptoms of fatigue, malaise, and anxiety or confusion. Absent symptoms in serious infection, especially in elderly individuals. Complications: adult respiratory distress syndrome, usually for adults, disseminated intravascular coagulation, acute renal failure, intestinal bleeding, liver failure, central nervous system dysfunction, heart failure, and death. Surviving sepsis campaigns. Guidelines for management of severe sepsis and septic shock. Diagnosis: before the initiation of antimicrobial therapy, at least 2 blood cultures should be obtained. That's why usually we give not one group of antibiotics, usually we give a lot, 2 or 3 group different antibiotics. At least 1 draw percutaneously, at least 1 draw through each vascular access devices if inserted longer than 48 hours. Other cultures such as urine, cerebrospinal fluid, wounds, respiratory secretions, or other body fluids should be obtained as the clinical situation dictates. Other diagnostic studies such as imaging and sampling should be performed promptly to determine the source and causative organism of the infection. May be limited by patient stability. Resuscitation bundle: serum lactate measured, blood culture obtained before antibiotics administered, improved time to broad-spectrum antibiotic. In the event of hypertension or lactate more than 4 millimoles per liter, deliver an initial minimum of 20 milliliters on kilogram of crystalloids or colloids equivalent. Apply vasopressors for ongoing hypertension. In the event of persistent hypertension, despite fluid resuscitation or lactate more than 4 millimoles per liter, HF central nervous pressure of more than 8 millimeters, and HF central venous oxygen saturation of more than 70. By the way, for coronavirus, main is the level of saturation, is the oxygen in the blood. So as you know, normally it should be more than 25%, but for coronary plus patients, usually it's less It can be 90, it can be 80, 85, 70. That's why so very high risk for these patients for artificial ventilation of the lungs. Also, we use fluid resuscitation, appropriate culture prior to antibiotic administration, early target antibiotics and source control, use of vasopressors, inotropes when fluid resuscitation optimized. About early target antibiotics, it's difficult, really difficult. Why? Because we should know sensitivity of this microorganism for that of this antibiotic. That's why we need to do analysis for sensitivity if we have some biological fluid for this analysis. What biological fluid can be like material for this analysis? Usually it can be, if we are talking about pancreatitis and pancreatic necrosis, it can be exudate from abdominal cavity. If we're talking about pleuritis, it can be pleural fluid which accumulates there. But sometimes we haven't these fluids, no any biological fluids, and in these cases it's very difficult to find targetedly antibiotic for these microorganisms. That's why also in these cases we give several groups of antibiotics like cephalosporins and some macrolides or carbapenems. Once we enter intramuscular, second one we enter intravenously. Third one we can use locally. If we talk about pleuritis, some pleuritis, or if we talk about some peritonitis due to pancreatic necrosis. Next, it's evaluation for adrenal insufficiency, stress dose corticosteroids administration, recombinant human activate protein C for severe sepsis, low tidal volume mechanical ventilation for ARDS, and tight glucose control. Infection control, appropriate culture prior to antibiotic administration, early target antibiotic and source control. On this picture you can see oligo-directed therapy, which is what we use. It's oxygen, of course, by the endotracheal intubation or mechanical ventilation, a central venous usually, or arterial catheterization, because we need exactly very safe gate intravenously or intra-arterial infusions or arterial infusions, sedation, of course, and other therapy, complex ICU department therapy. Early goal-directed therapy results. Very high percent, of course, of mortality. Standard therapy is usually 28 days. 28 days in which can happen mortality. Antibiotics used in sepsis. The drug use depends on the source of the sepsis, community-acquired pneumonia, third, ceftriaxone, usually, or fourth, cefepime generation of cephalosporins. Nosocomial pneumonia, we give cefepime or imipenem, cystatin, and aminoglycosides. For abdominal infections, usually imipenem, cystatin, or piperacillin, tazobactam, and aminoglycosides. So it's a must specific for these infections by the systems. Nosocomial abdominal infection is imipenem and piperacillin, tazobactam. Skin and soft tissues, vancomycin and imipenem, cilastatin or piperacillin, tazobactam. Nosocomial skin and soft tissues, vancomycin and cefepime. Urinary tract is best ciprofloxacin, aminoglycosides, acids, and one more is a levofloxacin drug. Nosocomial urinary tract infections, vancomycin and cefepime. CNS infections, vancomycin and third-generation cephalosporin or meropenem, and nosocomial CNS infection is meropenem and vancomycin. Drugs will change depending on the most likely cause of the patient's sepsis. Single drugs regimen are usually only indicate when the organism causing sepsis has been identified and antibiotic sensitivity testing. And usually we can change these antibiotics. Usually we begin from the easy antibiotics, usually the cephalosporins or penicillin group drugs, and then we give more harder, more stronger antibiotics. Why? Because will be resistance of these antibiotics for microorganisms. That's why we begin from the simple antibiotics and going for the stronger. Also, we can change our antibiotic therapy every 2 weeks. Usually 14 days, during 14 days happens resistance for antibiotics. And if we see that during our 14 days, we can have any positive dynamic in patients, we should change our antibiotics. New drug in treating severe sepsis. It's the first agent approved by FDA effective in the treatment of the severe sepsis, proven to reduce mortality. Activate protein C. Mediates many actions of body homeostasis. It's a potent agent for the suppression of inflammation, prevention of microvascular coagulation, reversal of impaired fibrinolysis. Also, this is materials for treatment, medications, and treatment using antibiotics by the clinical picture and etiology. You can see on this picture. Here you can see sepsis cascade, how it can be in patients with sepsis, septic shock, and SIRS. So, very often infection can combine and infection can recirculate. So, we can have in one patient peritonitis, pneumonia. Then we see positive reaction by our treatment for pneumonia, but after some time, after 1 week, 10 days, it can back. Same with all organs, like peritonitis and abdominal cavity organs, insufficiency for pancreas and other things. Activated protein C. Here you can see how it's activated. And usually protein C is also one of the factors which every time in patients with sepsis, septic shock, and SIRS will increase. You know when we're doing protein C, yes, it's rheumatoid factors every time doing when we think about some inflammation, but not every time protein C will increase. If it's surgical, some inflammation usually will be, we see blood analysis, and usually is leukocytosis, shift to the left, IRC, but not protein C. But in this case, usually protein C at every time will increase. Thank you very much. We finish our today's short lecture by SRS and sepsis. And maybe you have some questions. If you have questions, you can ask me in direct now. If no, thank you very much for your first lecture, and bye-bye. Thank you too. I see no any questions. Thank you very much for you too. Take care and bye-bye.